Good morning, everyone. Thank you for joining North Kansas City Hospital and Meritas Health's 2020 Occupational Health and Employer Wellness Conference, Healthier Employees, Safer Workforce. Like many conferences this year, this is our first virtual one. My name is Randy Wachter, and I'm Vice President of Marketing and Business Development at North Kansas City Hospital. I also oversee community and corporate health. I've been here 6.5 years. Today, we have such a great lineup for you. We really would like to thank our presenters, Sharon Mount, Lyndall Fraker, and our very own Michelle Lane for taking time out of their day to join all of us and share their knowledge. I hope you all received your conference packet with your jump drive loaded with today's presentation slides, also a little snack in the meeting agenda, and information on our services. Thank you so much for partnering with North Kansas City Hospital and Meritas Health Occupational Medicine Clinics for all your employer wellness needs, occupational health needs, inpatient injured worker needs, and after-hours care. As a community-based healthcare provider, we have the unique ability to address and support the needs of our employers and employees in the community. We understand what it takes to keep our communities and employees healthy. As you know, we customize our services around your needs, and our wellness programs are managed by registered nurses and health coaches who have the knowledge and resources to help employees make long-term healthy lifestyle changes. 2020 has come with many changes and challenges, and our team has done a fantastic job stepping up to the plate while continuing to provide excellent care for you and your employees. I'd like to introduce you now to all of them. Linda Covington is our network executive. She oversees all of the Meritas Health's 30+ clinics in the Northland. Many of you talk to some of these members every day, so we really wanted to put a name to a face. Erin O'Neill is smiling at you next to Linda. Erin runs the Meritas Health Occupational Clinics. She's our practice administrator. She runs both the campus and the Riverside clinics. You can find Heather and Jeremiah at either location serving as assistant practice administrators. And Cindy Stegall is your clinical team lead, and she's dedicated to the Riverside location. On the next line, there I am, and then there is Michelle Lane, who is our Senior Director of Community and Corporate Health. If you have ever used our emergency room services or after-hours care for your needs, many of you have probably talked to Leslie Martinez and Frida Price and Jim Brooks. I would like to take this moment to have a special dedication to Frida. This December, Frida will be retiring after 39 years at North Kansas City Hospital. Finally, we have Tina Wilson, who is our dedicated occupational health and wellness nurse. And then last but never least, I would like to introduce you to today's hosts, Casey Quintanilla and Charmaine Wood. They are the account executives you work with every day, and they will be hosting today's event. Again, I'd like to personally thank you so much for attending, and would like at this point to turn this over to Casey Quintanilla to introduce our first presenter. Thank you very much.
How about we try this again? You guys, sorry about that. This is a learning curve when it comes to virtual conferences and whatnot. Again, Randy Gannon, thank you so much for sharing the introduction and kicking off this conference with a bang. You got to meet the team, and our next speaker is Sharon Mount. She comes to us from Thomas McGee. She is a pillar of knowledge in the occupational world. And so I'm going to kick it off to Sharon. Thank you so much for being here.
Good morning, everyone. I'm sitting here with my mask off to do this and thought I was going to have it on, so I didn't wear makeup this morning. So you get to see me in all my glory this morning. We're going to do a brief review today of OSHA record keeping, and we're going to include some updates that they've come out with on the COVID-19 recording and reporting. Every year, probably mid to late January, we get tons of questions from our accounts regarding record keeping. So I think the review is really good to explain to you how you should be doing this, because if you're doing it how you're supposed to, you shouldn't have those questions in mid or late January before your summary forms need to be posted. You should have those questions as you go along throughout the year, because any case that is a recordable that has to go on your OSHA log is supposed to be placed on your log within 7 days of you having knowledge of it. Any of your insurance carriers or brokers, your loss control reps with those companies can help you if you have questions regarding whether or not a case is recordable or how you should record it within those 7 days of you finding out that you have a case. So we're going to go through what are the requirements, what forms do you need to use. Keep in mind those forms are available for your use off of OSHA's website. If we have the time at the end of my presentation, I'm going to show you how to find those. There were some updated record keeping requirements several years ago for electronic reporting, and we're going to review those a little bit and again talk about the COVID stuff. Then we're going to talk a little bit about the difference between recording and reporting. You also have reporting requirements for OSHA that are different than recording, so we're going to review that as well. Who has to complete the forms? Almost all employers. There are some exceptions to that. There is a small employer exemption. If you have 10 or less employees throughout the entire year, you do not have to keep those records. If you're self-employed and you don't have employees, you don't have to keep those records. Family farms with only immediate family members working at the farm. One of our accounts was the largest dairy farm in the state of Missouri. They had much more than family members working on that farm, so they had to do their OSHA logs. And then there are some low hazard industry exemptions. I'm going to show you how to find if you fall into that category on OSHA's webpage, also at the end of this if we have time. Otherwise, I have links for you throughout the presentation where you can find that information. But keep in mind, I have some low hazard industries that I work with that are exempt from the record keeping requirements, but they still keep OSHA logs. And the reason they do that, once a year, you may get a questionnaire from the state where you reside, whether it's Kansas or Missouri, wherever your company is located. And those questionnaires are mandatory, and they are asking information to submit to the Bureau of Labor Statistics regarding accidents, injuries, illnesses in your workplace. Those questionnaires are very hard to complete if you do not have an OSHA log. If you're keeping an OSHA log, the questionnaires refer to the exact lines and letters and numbers where the answer to those questions is contained on your OSHA log. So these companies that are exempt from having to do the logs keep them anyway. So when they get those questionnaires, they're really easy to fill out. Probably only takes you 5 or 10 minutes to fill them out. Another reason you might want to keep the logs, even if you're not required by OSHA, is it helps you identify trends and issues that you may want to deal with in your work environment to make your environment a safer place for your employees to work. So keep that in mind. You don't have to send them in to OSHA, you just have to keep them on file. Now there are some electronic record keeping requirements at this point in time, but we'll cover that in a few minutes here.
If you're using any temporary or leased employees, so if you're going through a temporary employment agency for your employees, keep in mind that temporary employment agency is going to have the work comp coverage for those employees. So should they get injured or become ill based on something occurring in your workplace, they are covered by work comp from their employer, and work comp and OSHA record keeping are totally separate things. You have to include their injury or illness on your OSHA log. It doesn't matter that you're not paying that work comp claim. If you are supervising those employees on a day-to-day basis, telling them how to work, what kind of work to do, etc., then their injury or illness must be recorded on your OSHA log. The injuries or illnesses that need to be recorded are any injuries or illnesses that result in fatalities, loss of consciousness, days away from work, restricted work activity, or job transfer. So if you have a light duty return to work program and you're offering an employee a position that's different than their typical position, that needs to be recorded on your log. Any medical treatment beyond first aid also needs to be recorded on your log. So it's extremely important when you send somebody to an occupational health clinic for an injury, they return to you the form from the doctor describing what their treatment is, because based on whatever that doctor writes on the form, that's going to determine whether or not that was medical treatment beyond first aid or just first aid. Also keep in mind, anytime there's a prescription prescribed to an employee, that is a recordable. Doesn't matter if they fill the prescription, doesn't matter if they take the prescription. If the doctor prescribed it, it makes the case a recordable. So it's very important for you to get those return to work reports from the doctor after they've been to the clinic. Some other conditions are required to be recorded. If you have an exposure to a bloodborne pathogen in the workplace, police officers, nurses, anybody that might have that bloodborne pathogen exposure, a needle stick, those have to be recorded on your log. If you have a hearing conservation program in place and you do your annual audiometric test and there's a standard threshold shift in somebody's hearing, that needs to be recorded on your log. And these are recorded as illnesses. And then if there is a TB infection in the workplace after an exposure to an active case of TB, that needs to be recorded as well. Shannon, my slides aren't advancing. There we go. Okay. Where do you have to keep your records? If you are a company that has a single establishment, you keep your records at that establishment. Know that you have to keep those on file for 5 years. Doesn't have to be paper copies. You can keep them on file electronically. A lot of companies have employees who report to one establishment but work elsewhere. If they are working elsewhere, those records need to be kept at the establishment where those employees are reporting to work every day. A good example of this, construction companies may have different job sites in different locations, and their job site may be short-term or long-term. If you have a job site that's long-term, you need to keep your records for that job site separate. You need to post your summary form for that job site on the job site. And then if you're a company that has more than one location, you may have an office in Kansas City, one in Omaha, one in Arkansas, then you have to keep separate records for each of those establishments. If you have employees that don't report to any establishment, maybe you have salespeople who don't report to any establishment, they're just out on the road, they work out of their homes. For those transient type workers, keep it at your central location, but provide those employees with a name and a contact number where they can reach people and have access to those records if they need information from those records. Employees have the right to review your logs and your summary forms. Records are kept for the calendar year. So sometimes companies get stuck in their fiscal year dates, calendar years from January 1st to the end of December. The log and summary form, which is the 300A summary form, and your OSHA log must be retained for 5 years. After 5 years, get rid of them. You don't have to keep them on file. You may enter a case. Remember at the very beginning, I said you shouldn't have questions come January about whether or not a case is recordable and should go on your log. You're supposed to enter the case within 7 days of its occurrence. Well, let's say you have a case, you enter it on the log. It's just a light duty case. So it's a restricted duty case. It's not a days away from work case. And within the first 7 days, that's what it is. You put it on your log as that. Well, maybe 3 weeks out, you discover this person is going to need surgery. So it's going to involve lost work time. You do have to update your log to reflect the change in that case. And to do that, you can just redline through your first entry and do a new log entry reflecting that. Now, I am going to have examples, and you should have seen them in your packet, on how to fill out the log or complete the log. So we'll look at that as well. But you do have to update your log to reflect any changes in the case status. You do not have to update your summary forms after those have been completed and posted. The summary form has to be posted every year from February 1st to the end of April, and it has to be posted in a conspicuous location for employees to be able to review it. So if you have an employee bulletin board, the place where you post notices for other things in your work environment, your 5-in-1 labor law posters, you can post your summary form in that location. Now, a few years ago, OSHA came up with an electronic submission of records that has started to be required. And prior to this, they didn't have that in place. Initially, they were going to require employers with 250 or more employees to submit more than just their logs and to submit more than just their summary forms. They were going to require that you submit your accident investigation reports, etc. All that has changed. The only thing that needs to be submitted electronically now is your 300A summary form. So that's just your totals of any fatalities, any days away from work cases, any restricted duty cases, any just recordable injuries. So the summary form is the only thing that gets sent in electronically. In order to do this, you have to go to OSHA's website and you have to register with their injury tracking application to submit your information electronically. There are some employers that don't have to do this, and you can find the list of employers that don't have to do this on OSHA's website. Also, employers with less than 250 employees in industries with high rates of injuries have to submit their summary forms electronically as well. If your peak employment in the previous calendar year, so January through the end of December, was lower than 19 employees during the previous calendar year, you do not have to submit your records electronically. This link right here will show you if you're on the partially exempt list. Now, partially exempt means you don't have to record, but you still have to report. And again, we're going to talk about reporting in a few minutes here. Those, I'm going to go back here. Those need to be submitted in March. So those forms don't need to be submitted until you have to post your 300A summary form. Remember, that's posted from February 1st through the end of April. So you do not have to submit electronically until March. And OSHA's website will tell you when those forms can be submitted through the injury tracking application. When they updated their record keeping standard to require the electronic record keeping, they also put some other stuff in there to eliminate any barriers to employees reporting injuries. Number one, OSHA hates safety incentive plans. If you're giving T-shirts or gift certificates or things like that to your employees because they went so many days or so many weeks or so many months without having an injury, they're going to look at that as they're paying or giving incentives to their employees not to report injuries. So if you have a safety incentive program in place, make sure that you're not doing it based on whether or not somebody's had an injury, but base it on maybe safety activities. Is this person attending required safety meetings? Are they doing things in regard to safety, not whether or not they've been injured in the work site? Years ago, and I remember this, when the Sprint campus was being built, the contractor that was the general contractor for that project gave away a Dodge pickup truck to, you were in a drawing for it if you were an employee that wasn't injured for a certain amount of time on that project site. So just imagine that. If somebody gets hurt on the job and they're losing their chance to win a brand new pickup truck, do you think they're going to report that injury? Heck no. They're probably going to say, oh, I did this at home, and they're going to go through their personal health insurance. So that's what OSHA is trying to eliminate. Now, people were up in arms for a while because it said that they couldn't post-accident drug test anymore because OSHA was saying that mandatory post-accident drug screens could be cause for an employee not to report an injury, especially if they're a drug user and they don't want to lose their job because they're going to test positive. OSHA is not saying that you cannot have post-accident drug testing. What they're saying is you should have a policy in place that outlines when the post-accident drug testing needs to be done, and you have to relate that you think the accident could have been caused or could have occurred because somebody might be under the influence. Best example of that I can provide to you, if you have an office and employee that works at their computer all day and they end up having carpal tunnel, that's probably not going to be based on the fact that they were under the influence of drugs when they were working. So you need to look at what is your injury, how did it occur, before you determine if there needs to be a post-accident drug test. Now, keep in mind that you need to determine whether or not a case is work-related before it gets recorded as an OSHA recordable. This is going to be really important when it comes to the COVID record keeping. A case is work-related if it's caused by any events or exposures in the work environment. If it was contributed to by events or exposures in the work environment. So let's say somebody has a previous injury or they were injured at home. So it's real important that you understand if your employees are injured at home, because more people get hurt at home than they do at work. You have an employee that's cleaning the gutters on their house, they're on an extension ladder, they fall off, they break their leg. They're going to have restrictions for what they can do at work that you need to ensure they're following, just like if it was an occupational health case. Because if they re-injure that leg in the work environment because you were not requiring them to follow their work restrictions, it's going to end up being a work comp case for you. So if you have a pre-existing condition or a previous injury and your job at work contributes to an aggravation of that, it could be a work-related injury that's now going to be put on your log. If the injury occurs away from your work establishment, but the worker was engaged in a work activity or is present at that activity because it was part of their job, that is also work-related. So if you have traveling employees and they're driving to the airport to get on a flight to go do a presentation somewhere, they're in the course and scope of their work. So if they have a car accident on their way to the airport, it is work-related. Keep in mind, if they're outside of your establishment but engaged in work activities, it is work-related. So some special situations that are work-related, if you have employees that are engaged in apprenticeship programs or vocational training and you're paying for that as part of their work, and it's required by you, of course, that's going to be work-related if something happens. If somebody's on break, so they're in the restroom at your office or they're in your storage closet or any place located on your premises, if they have an accident, it is going to be work-related. During this COVID stuff, we were sent home, I think, the day after St. Patrick's Day or right before St. Patrick's Day, and most of us are still working at home. If I get injured while working at home and it has to do with my work environment, it is going to be a work-related injury. Now, if I fall down my basement stairs while I'm working at home because I went down to the basement to get something that has nothing to do with work, that's not work-related, especially if I have a bunch of junk piled on my stairs, which is unsafe. So you need to really delve in and do your accident investigation and find out how somebody was injured if they are saying they were injured at home while they were working at home. I already talked about the travel on business. This includes if you're just going to see customers out in the field or going to see clients out in the field. If you're in your car traveling to customer locations, you're on business, work related. Now, let's say that you go into your office when you're not on the clock to do some personal stuff. Say you need to make copies of something. So you're going in to use the copy machine. Or you're taking a vacation day, but you're bringing your kids into the office to let everybody see your kids. They haven't seen them in a while. If anything happens to you in the work environment when you're doing things like that, you are not there as an employee at that point in time. You're there as a member of the general public. And if something happens, it is not a work comp case. It's not a recordable. If you're voluntarily participating in a wellness program, if you have yoga classes or anything like that at your workplace, it's not mandatory, it's voluntary, it's not work related. If you're having lunch in the break room, if you're preparing food, if you're drinking, whatever that is for personal consumption, that's not work related. Personal grooming, self-medication for non-work related conditions, or anything intentionally self-inflicted is not work related. So suicide on the job is a big topic right now, especially in the construction industry. But if somebody commits suicide in the workplace, that is not a work related injury. It was self-inflicted. If you have a motor vehicle accident in a company parking lot or on the access road while you're coming to and from work, that is not work related. Now, it doesn't mean that it's not going to be a work comp case and that your insurance carrier isn't going to pay for the medical on that, but it is not work related for OSHA purposes. So there's a difference between work comp and OSHA requirements. The common cold or flu, not work related. Contagious diseases like hepatitis and TB are work related if they are contracted in the work environment. And again, we're going to get to COVID in a minute here, so I don't want to throw that in here. If your employee was not engaged in any activity whatsoever at the workplace that could have affected the part of the body that was injured, or if they were never exposed to any chemical or physical agent that could have caused their illness, then that is also not work related. So when we come to COVID recording, know that OSHA is providing guidance on this. It changes frequently. At the beginning of this, they said you really didn't have to record anything, and then they updated it. So this changes frequently, and I ask that you check OSHA's website frequently if you have questions about this. And if you go to OSHA.gov, they have a fantastic website, and they have a specific link where you can get all of their COVID information. You have to record a COVID case You don't have to record it, number one, unless there is a positive test result for that employee, unless the case is work-related. So go back to our previous slides. You're going, how do I know it's work-related? We'll go through all those checklists to determine if it might be work-related. So did they have exposure in the workplace? Is your company doing nothing to prevent the spread of COVID? Is your company requiring masks? Are they requiring social distancing? Are they notifying you if somebody that you have been close to has tested positive so that you can quarantine and contact trace? If all of that is going on, you're probably not going to have a COVID-related recorded case. Healthcare providers, EMTs, paramedics, police officers, firefighters, that might be different. Their cases may be work-related if they were exposed to somebody in the course and scope of their duties that was positive for COVID. If the case results in death, days away from work, restricted work or transfer, or medical treatment beyond first aid, or loss of consciousness, then it has to be recorded, just like any other recordable case. What OSHA is saying that you as an employer have to make a reasonable good faith effort to determine if the case is work-related. A really good example of this are the meatpacking plants that earlier on in the COVID scare were having numerous employees test positive. Those cases were more than likely work-related because everybody working in certain areas was testing positive and getting sick. So just make sure that you're dotting all your I's, crossing all your T's, making sure that you're doing the right thing when it comes to COVID to avoid having to record those on your OSHA log. Here's some examples of something that is likely work-related when it comes to COVID. If you have several cases among people who are working close together and there's no other explanation, they don't have family members at home that were positive, they don't have a significant other that was positive, it might be work-related. If somebody contracted the virus shortly after they had close exposure to a customer or coworker with a confirmed case and there's no other explanation, it might be work-related. For those that are working with customers, face-to-face contact with customers all the time, and they're not using protection such as their masks or plexiglass barriers, etc. If they're having face-to-face contact with customers, they may have been exposed in that way. Unlikely work-related, if it's a lone worker and they contact it, their duties don't involve frequent contact with the general public, it's probably not work-related. Or if your employees associate with someone outside of work who has tested positive, it's probably not work-related. When an employee is traveling, there are some times that they're not considered an employee when it comes to recording. So anytime they're engaged in the work activity or anytime they're working in the interest of the company, like I said previously, if they get hurt or injured, it is going to be recordable for OSHA purposes. Once that employee checks into a hotel or a motel, they have established a home away from home. So let's say they fly to a location, they go visit clients for the rest of the day, then they go check into a motel. After they check into the motel, they go out to dinner, or they decide to go out to dinner and to drinks, and they have a car accident. After that, it's not going to be a work-related injury because once they checked into that motel or hotel, they established that home away from home. Normal commuting, if they're commuting, let's say they stay in a hotel all week long and they're going to one specific job location every day. When they leave the hotel and drive to that job location, that commute is not considered work-related. But then when they check out of the hotel to go to the airport and fly back home, that is considered work-related because they're traveling on business at that time. So again, this is to repeat the criteria for recording work-related death, loss of consciousness, any cases where somebody is required to spend days away from work, not including the day of injury. So if somebody gets hurt at work and you send them home for the rest of the day, you don't count that as a days away from work. Any light duty work or restricted work activity is considered recordable, and any medical treatment beyond first aid. These are the 3 forms that OSHA has available on their website that are required to be completed. The Form 300 is your log. The Form 301, most employers don't do this form. It's kind of like an accident investigation report. As long as your in-house accident investigation report contains the same information as the 301 form that comes in OSHA's packet, you don't have to use the 301 form. You can use your internal accident investigation report. My suggestion is that you keep that report in the file with all the medical information for that employee's injury or that employee's case. You can also keep that form with your logs. And then the 300A summary form is the form that gets posted every year from February 1st through the end of April. So I have examples of here, and I'm going to have to throw my glasses on, of how to record different cases on your forms. So if you have a case that results in a fatality, you would fill out the person's name, what their job title is, the date this occurred, where the event occurred, and what caused the injury. So this gentleman fell off a ladder and it resulted in a fatality. So then you have in the next column where you're classifying the case, was it a death? Did it involve days away from work, job transfer or restriction, or other recordable case? So this would be marked under column G as a death. Then you skip the other one because that's where when you're counting your days away from work or your days of restriction or job transfer. And then you go to the last column and select the type of injury. And it is just an injury. It is not, and I can't really read these right here, but one of them is poisoning, one of them is illness, one of them is hearing loss. I think the other is a skin disorder. So if you had a rash or something like that, it's none of those, it's just an injury. So that's how it would be recorded on your log. Now let's look at how do you record a case with days away from work. So Shanna was, there's the job title, pouring a dock, and he got poisoning from lead fumes. This case involved days away from work, so it gets marked in column H. You count the number of days that Shanna was away from work. You include Saturdays and Sundays, and you cap that at 180 days. So if this happened on a Thursday, you don't count Thursday because that's the day it happened. You start counting on Friday and you count 12 days from then, and that's when they came back to work. This is a poisoning. Another example of poisoning would be carbon monoxide. If somebody's running a generator or something and they get overwhelmed with fumes from carbon monoxide, that would be a poisoning as well. That's how that gets recorded on your log. Now, I know if you're not really familiar, you hardly ever have accidents, you're not familiar with how to fill these out, it can be daunting. And that's when I say pick up the phone, call your loss control rep with your carrier or your broker, and they can usually answer these questions right off the top of their head and tell you how to record this on your log. Don't wait till January, get it on there within 7 days of occurrence. Another thing that we get asked a lot is, can you do my OSHA logs for me? We're an insurance broker, so we have claims reps, so they track our claims of our clients. We also have an in-house TPA, and they manage claims for accounts. We can't do your OSHA logs for you. You need to do your own OSHA logs. We can assist you and help you with how to complete them, but we can't complete them for you. Now let's look at this one. And this is recording a case with restricted work activity or job transfer. And I also included on this one a case that started as a restricted duty case, but then ended up being a days away from work, and how you would record that on your log. So Sam down here sprained his left foot by falling over a box. He was able to return to work, but he had some restrictions. So he couldn't perform all the job duties that he would typically perform as an electrician, such as climbing a ladder. He couldn't climb a ladder because his foot was injured. So he was on restriction for 10 days. So you would record on the job transfer or restriction 10 days in this column. Again, it's an injury. So you mark it as an injury over here on the right-hand side. Now, Ralph had a back injury, which started as restricted duty. So he had some limits on what he could do from work. But several weeks later, that turned into something that required days away from work. Maybe he had to have back surgery. Although I don't think he would be out 5 days for a back surgery. But let's just say it got worse and he had some days away from work. When you record this in the classifying the case, you record the more serious of the injuries. So it's going to be a days away from work case. You don't record it as a days away from work and a job transfer. You record it as the most severe, but you do show both of the days on the column where you count the days. 14 days restricted, 5 days away from work. All of these days of counting are capped at 180. So if you ever have a serious case, once you reach 180 days, you can quit counting. Also, let's say this injury with Ralph occurred on December 3rd. It stays on that log for that year. It doesn't go on the log for the following year, and you still update it on your log for 2020 as you go. I've already said that. Anything with medical treatment beyond first aid, you just record it as an other recordable case, and you record it in the injury thing column. Medical treatment does not include things that are included in managing and caring, or I'm sorry, medical treatment is managing and caring for a patient for the purpose of combating disease or disorder. So a visit to a doctor for observation or counseling is not recordable. Diagnostic procedures aren't recordable. Anything that can be labeled first aid is not recordable. So you could have somebody go to the hospital in an ambulance, get to the emergency room, have an x-ray. The x-ray is negative. There's no prescription provided. They get released. That's not a recordable for OSHA purposes, but it's going to be a big work comp claim because they're going to pay for the ambulance in the emergency room and the x-rays, etc. So again, work comp and OSHA record keeping are different. I'm not going to go through this because I've been given the 5-minute signal, and I want to make sure if you have questions, I can answer them. This slide right here is everything that is considered first aid under OSHA record keeping requirements. It's real important you get the medical note with the employee when they come back from the doctor, because if any of these things are done when they're at the clinic or at the emergency room or wherever they go, this is not recordable. It's first aid. Anything beyond this is going to be medical treatment. This is the summary form that gets posted every year. Note that this form has to be completed by a high-level executive in your organization and signed by the or it doesn't have to be completed, but it has to be signed off on by a high-level person in your organization. And again, just because a case involves a work comp claim does not mean it's an OSHA recordable. I'm going to go really fast here. You have to report to OSHA within 8 hours any work-related fatality, period, okay? Even a heart attack at work needs to be reported to OSHA within 8 hours. They're going to determine whether or not they investigate that. Within 24 hours, you have to report inpatient hospitalizations, amputations, and any loss of an eye. That reporting has to be done during regular business hours, and you have that contact information in the slides. I am sorry I talked way too much and took way too long, but I wanted to stop now since you have the contact information and have the OSHA website information, and find out if we have any questions on what I covered.
Hi, Sharon. Yes, we do have a couple of questions coming in. Our first question is from Krista. Thank you so much. Are school districts exempt from submitting OSHA logs and reports?
Some are, some aren't, and I would suggest that you go to OSHA's website and look. Private schools have to complete them, some public schools don't. The electronic record keeping might be required, so I would suggest that you go find those exempt or partially exempt lists, but I do know school districts receive those letters from the state annually where they need the information for the Bureau of Labor Statistics. And if you're not keeping a log, it's really hard to get that information to answer those questionnaires. So if you don't have to do it for OSHA purposes, I would suggest you do it for yourself and keep it on file in case you have to do the state reporting requirement.
Excellent. The next question comes in from Tina. Suppose someone is off the clock and walking to the car and falls and breaks a leg. Is that considered work comp?
I think some work comp carriers would pay for that because it's on your property. It is not an OSHA recordable, but that could be a work comp claim, yes. Especially if they fell in a hole or something that was defective in the area where they were walking.
Would an injection on the first visit be considered first aid?
It depends on what the injection is. If you're getting a tetanus shot, that is first aid. Your hepatitis vaccines that you might give for your employees or offer to your employees, those aren't work comp cases at all. Those are preventative. So it depends on what the injection is. If it's an antibiotic, it might be considered a work comp case. So you have to know what the injection was for. It's so important to know and track the medical treatment that your employees are getting if they do have a case. It's so important. And it's so important for you to have that close relationship with your clinic so that you can maintain that relationship and know what's going on and work with them to try to prevent your cases from becoming recordables.
This one comes in from Gary. What is your view of including safety as part of the job description with salary based on overall performance that has safety as a component? For example, companies routinely list safety as 20% of the employee performance and factor for annual compensation as a way around OSHA's militant stance on safety incentive programs.
Can I take a wild guess and say that's Gary Clevenger?
You would be guessing correctly.
Gary, it is so nice to hear from you. I haven't seen you in years. I agree with you on your employees. You need to have a safety component of those performance evaluations. That is much better than having a safety incentive program. And you can monitor and reward employees for safety performance through that evaluation process. So I don't know if I'm answering his question. I don't know that he had a question, but I agree wholeheartedly that that is one of the best ways to get away from OSHA saying that you're incentivizing your employees to not report injuries, is to have tasks and performance evaluations and specific activities that they're required to do as part of safety. Safety, Gary will like this, safety first is the stupidest slogan ever, and I'm a safety person. It's stupid. Don't say safety first. Don't put that on all your stuff. It doesn't happen, so nobody's going to listen to anything else you say. Safety has to be just as important as cost, quality, schedule, etc. And if you put it on the same level as all of those, you're going to be successful. Don't put it at the bottom. Make it just as important as everything else. Treat it just like everything else. Measure it just like everything else, and you're going to be successful.
COVID. How would you be sure that the employee is infected at work in order for it to be considered work comp?
Well, first of all, what kind of contact are they having with others in the work environment? Are they working with the general public? Do they have face-to-face contact? Do you have a COVID policy in your workplace that requires masks if you're within 6 feet, not practicing social distancing? You should have a policy in place of what you're doing to prevent the spread of COVID in your workplace. And if you have nothing in place and there's face-to-face contact and you're having meetings in a conference room and people are on top of each other and you don't require mask wearing, it's going to be real hard for you to say it didn't happen in the workplace, especially if 5 people sitting at your conference table with 12 people there all come up with positive COVID tests. So if you have protocol in place to prevent the spread, and it's only one person in your work environment that gets it, you can probably make a good faith effort to say, this did not happen in our work environment. So make those good faith efforts to protect those employees, and then you can, I'll put that in quotes, prove that it didn't happen in the workplace.
This question comes in from Tara. If an employee refuses light duty, do you have to record the injury as days away from work?
If the employee refuses light duty, number one, you don't have, your insurance carrier doesn't have to make any indemnity payments. So the medical costs will still be paid, but their payments for sitting at home and not coming to work will stop. They don't get those anymore. And it doesn't matter that whether or not it goes on the OSHA log. If it's a recordable case, it still has to go on the log.
You guys, these are great questions.
They are great questions.
They are. I've got another one that is coming in from Lindsay. What if there is a mask policy, but social distancing is difficult due to the nature of work? In this regards to COVID.
Well, you should have other things in place. I've seen locations where if the social distancing is not possible, they've put up barriers. If you're in cubicle work areas, like in our office, we have sit-stand workstations. We can't stand anymore. We have to stay seated so that we're in our cubicle area. We can take our mask off if we're in that area. We cannot go to other cubicles and visit with other employees or coworkers. Once we get up from our desk, we have to put our mask on. So you might just look at what is the close contact. Is there any way we can distance these people? If we can't distance them, can we put up barriers? OSHA will always say that you need to look at engineering controls before personal protective equipment. So if you can put up barriers, they're going to expect that to be done.
So again, from Lindsay, they clean and move contents for clients as a restoration company. So it's not stationary work.
Okay. So I'm assuming they need employees to help each other moving furniture and things like that. Am I assuming correct there?
You are assuming correct.
Okay.
Yes.
So those employees, if they're working in a mask, and a lot of times they're not right on top of each other, Do you require them to wear gloves as well? Are they riding in a vehicle together? Sometimes you'll see landscaping crews or mowers, they go out and they're mowing yards. And when they get out and start mowing, they all take their masks off. But if they're riding together in the vehicle, once they get back in their vehicle, they all put their masks back on. So you just kind of need to look at your work operations and see what you're doing. And if you feel like you're doing everything you can to prevent that exposure, and you might do a screening questionnaire for those employees too. And it's just real short questions. Do you have a fever? Have you been exposed? Have you quarantined? Have you traveled? Your carriers or your brokers can get you a real short little questionnaire as well in order to screen those employees prior to them showing up and working with their coworkers.
All right. Sharon, thank you so much for answering.
Casey, I will say that I know our contact information is at the end of this slide for Thomas McGee, which is a general email. I'm going to throw out my email in case anybody has any more detailed questions. And it's just smount@thomasmcgee.com. If you have any other questions that I didn't get to today or need more detailed information, feel free to shoot me an email.
Excellent. Thank you so much, Sharon. Now it is 9 o'clock. We are going to take a small break before our next presenter. Be kind to yourself and grab your snack that you received in your conference packet. And we will see you back here at 9:10. Again, I will put her email in the chat section. For anyone that was asking about the slides, if you could get slides, print them off. In the conference packet that you received with the information, there was a jump drive in there. The slides from all 3 presenters are preloaded on that jump drive for you guys to review and look at. Okay? So we will see you back here at 9:10. Thank you again, Sharon, so much. I always learn so much from you, and looking forward to the next 2 speakers. Thanks, guys. See you soon. Hi guys, welcome back. We are back for our second half of the conference. I hope that you are ready for what we've got in store. We've got 2 more speakers and a virtual tour of our renovated clinic. I can't wait for you to see it. So our next speaker is Michelle Lane. She is been in the nursing field for over 20 years. She is going to talk about complaining and the toxic environment that it has on your brain. So take it away, Michelle.
Awesome. Thank you so much. So it may be too early to talk about another virus, but I'm going to do it anyway. We're going to talk about a virus that can cause you to have high blood pressure. It can cause you to lose friends. It can cause you to have a heart attack, even a stroke. It can make your brain mimic Alzheimer's disease, making you depressed and angry. The virus that I'm talking about can also just be passed on easily through casual contact between the people that you work with, the people at your family, just by being around them. So complaining rewires your brain for negativity. So it makes you look for and attract negative experiences. So complaining dumps adrenal cortex, the cortisol hormone, into your body. And that's what causes you to be overweight and to have the strokes and the heart attack when you do too much complaining. So the average person complains about 15 to 30 times a day. I like to say that complaining is kind of like bad breath. You notice it when it comes out of somebody else's mouth, but maybe not so much your own. So what we're going to do today is talk about how to identify people that are complaining, the 5 main reasons that people do complain, and some tricks to maybe stop people from complaining around you. Additionally, we're going to talk about the most important thing, which is yourself, and how you can stop yourself from complaining. So first, I want to be totally clear. I want to talk about the type of complaining that we're going to talk about. So when you call the help desk because your phone is not working at work and you need to explain a problem and get resolution, that's not complaining, right? I go out to eat to 54th Street. I love their tortilla soup. I sit down, I order the soup, and it comes and it's cold, right? So the server comes over and says, "Everything okay?" And I just kind of nod and don't say anything. But the minute she walks away, I immediately say to my friend, "Of course, I've come here 50 times. I always get the soup. It's cold. Oh my gosh." And it's this kind of like, how dare this happen to me type of communication that we do with ourselves and other people. That's the complaining I'm talking about. It's not complaining when the server comes over and says, "Hey, how is it?" And you say, "Hey, you may not have known this, but the soup is actually cold. Do you mind if I just heat it up for me real quick?" That's not complaining. That's not what we're talking about. So there's no ego in just explaining what the problem is and asking for resolution. So let's talk a little bit about happiness. I'm going to talk about the research related to happiness. And when I talk about research, I'm not talking about just one study. I'm the girl that has a bedside table full of research articles that have sticky notes on them and they're flagged. I mean, it may have actually led to my divorce. I mean, my bedside table is stocked full of research articles. So when I talk about research, I have vetted out whatever study I'm sharing with you. It has been studied at least 20 times, has a large population of people studied. There's no bias in the study. And so what I've learned about happiness is really interesting. So 10% of your happiness is actually just your circumstances. Despite what people think, you get used to your circumstances. So that's why you see these little children on commercials for feeding starving children, and they're smiling and they're laughing with their little starvation bellies and their little Buddha eyelashes, because they're used to that. They don't know any different. So the other thing, just as a side note, that showed up in the data about happiness is that people that have had some sort of adversity in their life, they're actually happier. So it's the only thing I can give thanks to having a bad childhood is that those people get some perspective over time about the adversity that they faced, and they get this resiliency and they're able to overcome challenges. So people that have adversity in their life are actually happier. The second part of how we get our happiness, and the biggest study about how our happiness shows up in ourselves, came from the University of Minnesota. It was a gigantic study of over 10,000 twins. And what they realized is that everybody has a
happiness set point in their body. And that's 50% biologically determined from your genetics, your family. And so there's some other studies coming out about telomeres. And I don't know if you know what telomeres are, but telomeres are like these little plastic shoelaces that are the end of your chromosomes. So our life, all we do is cells die, we make cells. Cells die, we make cells. We're just this continuing, evolving cells. And so as those cells recreate themselves, those little plastic shoelaces, you know, the little caps on the end of our chromosomes get shorter and shorter with just a different group of people. They get shorter quicker with people that are unhappy and also with people that are complaining. So there's great studies coming out of Duke University about these little telomeres at the end of our chromosomes. There's also some studies about aging. And so people that age quickly or show signs of aging also have shortening telomeres quickly. So just a little side note about happiness. But ultimately, 40% of our happiness comes from us, right? So you may not want to hear that, but your existence and the happiness of your existence comes from your own internal, what are you telling yourself? What are those thoughts you're having? And your external communication. So 40% is controlled by your thoughts, actions, and behaviors. The best way that I can kind of share an example of this is two friends. They're sitting down and they're going to eat lunch, and they're on a construction job, and it's a beautiful day, and they're sitting on the tailgate of the truck and the sun's shining, and they got about 15 minutes to eat. And one guy opens his lunch, he starts eating his lunch real quickly, and the other guy opens his lunch, kind of sighs a little bit, but says, oh man, meatloaf. But kind of guy glances at him, his buddy does, and the guy just starts eating his lunch, right? No big deal. Second day, same two friends sit down, have lunch again. First guy sits down, starts eating his lunch. Second guy opens his lunchbox, more exacerbated. Oh my God, meatloaf, I hate meatloaf. It just continues to eat, right? Third day, sit down, same two friends. First guy opens his lunch, starts eating. The second guy opens his lunch. Oh my God, I hate meatloaf. I'm so sick of meatloaf. And his friend looks at him and goes, dude, why did you have your wife make you something else for lunch? And the guy says, I make my own lunch. So if you don't remember a single thing that I say today, the ultimate message I need to give you is you make your own lunch. You make your own lunch by the thoughts that you have, the words you speak, and the actions that you take. You make your own lunch. All right, so let's talk a little bit about complaining. So complaining is really just focusing on the problem and not a solution. It's typically why we have meetings, right? We probably wouldn't even have meetings at all if we didn't have problems to get together and talk about. So we get together, we talk about the problem, maybe talk about the solution a little bit, but then we just talk about the problem. So complaining is also seen in venting. So venting is the expression of emotional dissatisfaction. And I need to warn everybody, it turns out that people that vent or say, I just need to vent, basically they have an agenda. They don't want to hear any of the things that you have to say to help them with their situation. They're really just focused on sharing their horrible experience that they've had. And they're doing it because they really just want attention. So people are social creatures, and venting really is just, hey, listen to me, I'm frustrated. But instead we complain about a situation. So we're going to talk a little bit about people talk about problems and not solutions. Also, complaining is really bad for your health. So in Will Bowen's book, A Complaint-Free World, he's actually a local guy, Kansas City native. His book is fantastic and I recommend it to anybody, but he talks about this man who had migraines for most of his adult life. Every day he would come home from work and his wife would say, hey, how's your day? And he would say, oh, on a scale from 0 to 10, my headache is about a 7. But notice that his wife did not ask about the headache report, right? She just said, how was your day? But this is this routine that they had. And what he noticed after reading the book, A Complaint-Free World, is that he always talked about his headache because he didn't really have anything else to say. It was just what automatically came out of his mouth. So he decided to stop complaining about his headaches. And he did. And he came up with things to talk about with his wife. And the relationship is even better than ever before. And now that man is actually the CEO of Will Bowen's A Complaint-Free World. And he's just taken it to heart, and he goes around and talks about his experience and how stopping complaining changed his life. This talks a lot about the mind-body connection, right? So if we complain, our body hears it, right? And it gives us something to complain about. You see this with, when I wake up and I don't feel good, I go to bed feeling fine. I don't know what's happened as I get older. I wake up injured every day. And if I complain about it in my head and I remuse about like, oh my gosh, my back hurts, my neck hurts, the worse I feel, right? But if I just shake it off and say, hey, today's a new day, I'm going to stretch, I feel better. So there's a mind-body connection there. So if complaining is focused on the problem, it's bad for our health, it's also really bad for relationships. So how you describe somebody is how they are in your head. You're going to tell yourself a story. And maybe this is the reason that I got divorced. I know his girlfriend didn't help, but I used to go out on Thursdays with my friends and we called it group therapy. And we would complain about our spouses, right? And all men are dogs, okay, right? We just sit there and complain about, oh, this, that, and the other. And so when I got home, this whole all men are dogs scenario I played out in my head, it's not a surprise that old Yeller was in the chair when I got home, right? Because I'm looking for things to support my scenario that he's a bad person, right? And so I noticed his socks on the floor. I noticed that he, used his spoon for ice cream that he eats every night and he left it in the sink. Why can't he put it in the dishwasher, right? And those are the things that you talk about and you complain about. But really, I needed to be more positive and say, hey, thanks for letting me go out with my friends and watching the kids. But I had sat there and talked and complained about him for the last 2 hours. So of course, when I come home, that's at the forefront of my mind. So if complaining is bad for our health, it's focused on the problems, it's bad for our relationships, it also limits your career success. Nobody ever said must complain frequently on a job description, right? I mean, that's not something you see. And I had a great life lesson really early on in my career. I worked at a local hospital, not North Kansas City Hospital, I gotta say that as a side note. And I worked with this great group of nurses. They were so smart. I had never been around anybody that was as intelligent as these guys. Their skill set was amazing, but the culture was absolutely toxic. They would do their skills in the room and then they would go in the break room and then they would complain about the doctors and they complain about each other, whoever wasn't in the room. They'd even complain about the patients, about how hard it was for them to turn over, how long it took the wife to explain whatever was going on with the neighbor's dogs. It was just absolutely toxic. Our outcomes were horrible. Our patient satisfaction was horrible. It was just a miserable place to work. And what ultimately happened was that guy was so astute. He picked up on that culture right away. And he made a policy surrounding complaining in the workplace. And he held people accountable to it. And he talked about positively. And his mantra was no weeds in the garden. I don't ever let weeds grow in the garden, because complaining is toxic and it causes other people. It's like there's complaining ninjas out there, right? It's a competitive sport. If one person complains about, oh, I tripped and stubbed my toe last night while running in the woods, well, then the next person has to top that, right? And then it was like, oh yeah, one time I fell down the stairs and injured my, ACL or whatever. You don't go to like, oh yeah, I went and got my nails done and I, got a little bubble in my paint, right? You don't do that. It has to crescendo upwards. So that's why you have to stop complaining from the get-go, so it doesn't get to that high level of complaining where everybody's trying to out-complain each other. So if it's all these things, right, why do people freaking complain? So I didn't do this work, but Dr. Robert Kowinski did, out of Clemson University. He said that there's 5 reasons why people complain. And Will Bowen came up with an acronym on why people can complain. It's GRIPE, G-R-I-P-E. So I'm going to roll through the 5 reasons people complain and kind of give you some hints on how I try to get people to stop complaining and maybe meet their needs in a better way. And so it's a more positive environment around myself. So I got to tell you though, before I go any further, like, you are going to notice complaining like never ever before. It's going to be like before when people smoked, and then now, nobody smokes, but when you see people smoke, you're like, oh geez, wow, okay, that's unusual. We are surrounded by a funk of complaining and we just don't notice it, but you will now that you're going to hear me talk about the 5 reasons people complain. So the first and most popular reason people complain is to get attention. So we are people that want connection. Everybody wants connection. Brene Brown is a social psychologist, and she talks a lot about connection and human connection. But this is why we get in an elevator and it's awkward, right? It's so awkward because nobody is recognizing each other. We're all just kind of standing there in silence until somebody complains about the weather or how slow the elevator is or their health or where they're going or the traffic, right? And then you feel the energy in the elevator kind of, okay, because we've acknowledged each other. So we've given each other attention, right? So, you know, I used to come up to the nurse's station when I was a nurse and I would sit down to do my charting with my coffee. And immediately I would start complaining about whatever it was that happened in the room. It wasn't that I wanted to complain. It was that I just wanted attention. I wanted to sit down and chit chat with my friends. And instead of just being positive and saying positive things, I would just complain for attention. So the best thing you can do when people complain just for attention about silly things, the weather or whatever, you say, hey, what's going well, right? And so they still complain, you say, hey, what's going well? And one of two things are going to happen. Either they are going to tell you what's going well, or they're going to think you're a weirdo and they're going to leave you alone and they're going to quit complaining around you. But either way, you're going to win. So when people complain around you just for attention, say, you know, what's going well. So I think we should have like, you know, pay attention to me tattooed across our foreheads because we want connection. And that's one of the main reasons that people complain around each other. Another reason that people complain is to remove responsibility, right? So you give somebody a task to do and they don't want to do it. So they're going to complain about all the circumstances surrounding that situation instead of actually doing the task, right? So you give me this report to do, but you know how marketing is, they take forever, their attention to detail, everything needs to be branded right. And then it went over to printing and print takes this long. And so I am removing responsibility. If somebody was to suggest ways to get around, you know, this, that, and the other with marketing, I'm not going to pay any attention to them because I'm trying to create a story about how I need to have the responsibility removed from me because I didn't do what I was supposed to do. So the best way to deal with this is say, hey, if it was possible, how would you do it, right? So somebody starts to come at you with, oh, I didn't get this done because of this, and this was the problem. Then you just simply say, hey, so next time, now that you know this, how would you do it differently in order to get that done? The third reason that people complain is to inspire envy. So I call this like the humble brag. Because in our culture, it's not okay to brag about your new iPhone, but it's okay to complain about your new phone and the 5 different lenses and how it's so complex. You don't know how to take pictures and you have to have your daughter do it. You can tell I've probably done that myself, right? So it's okay to complain about it and still do the same thing. I'm complaining about this great fortune that I've had and able to share about it, but it really is a form of complaining. And another way of this kind of bragging, and it's kind of harder to understand, is when we talk about other people. So gossiping is actually complaining too. So when we gossip about other people, what we're really doing is bragging that we don't have that character flaw, right? So if Leslie's always late for work, and I say that to somebody, Leslie's always, you know, late for work, the best thing that you can do is compliment the opposite of that. So if, you know, I'm complaining to Casey, oh my gosh, Casey, Leslie's always late. Casey should say to me, you know what I love about you, Michelle? You're always on time, right? If I make fun of something that somebody's wearing, you want to compliment the opposite. You want to say, you know what I love about you, Shanna? You always dress so cool. So gossiping is actually a form of complaining. It's unhealthy. And really what that person is doing is bragging that they don't have that characteristic or that quality about them. That's what complaining for bragging is. So the next reason why people complain is for power. We see this every 4 years, and in our government, and I'm not talking about the Olympics. People complain for power quite a bit, and they also do it in families. I see it in my own family. My Uncle Brian is always complaining about my Aunt Marcy, and there's nothing I can say that's going to make it better. And what he's doing is, if it goes down between my Uncle Brian and my Aunt Marcy, he wants to make sure that I'm on his side, right? So he's complaining for power in that family, that if something happens, that, you know, everybody's going to be more siding with him. I come from a litter of children. I have a large family. And, you know, my mom was really good about this. When us siblings used to complain, she used to always just be Switzerland. She used to stay out of it. And she'd say, sounds like you guys have a lot to talk about. If you want me to send in, I will. And so that's what you need to do for people that are complaining about other people for power, people that you work with, you're complaining about that other person, basically trying to get them on your side. So in case it goes down, who knows what will happen, but you know what I'm talking about. You know those people that complain for power in work situations or in family situations. The best thing you can do is just be Switzerland and stay out of it. The fifth and final reason that people complain, and I unfortunately am guilty of this, is to remove poor performance. So I try to be a golfer. I'm an awful golfer, but when I swing the club at the ball and it slices off to the left, the first thing that pops into my head, of course, is somebody sneezed on my backswing, or the sun is in my eyes, or my hands are sweaty. So this is complaining to excuse poor performance. And a lot of us do this pretty commonly, but the best thing you can do about this is you can just basically say, hey, how are you going to improve next time? Don't try to, you know, go through every step of what happened wrong with their performance. You're wasting your time, right? So just acknowledge the fact that somebody's complaining about their poor performance. Don't listen to them go through step by step, and just say, hey, if you do it next time, how's it going to look next time? So those are the 5 main reasons that people complain. And the acronym GRIPE. People complain to get attention, remove responsibility, brag or inspire envy. They complain for power, or they complain to excuse poor performance. And some little tricks that you can use, you know, to try to get people to stop complaining around you. But remember, I told you that people can be complaining ninjas, okay? So I know people that can complain for attention and also complain for poor performance all at the same time. So that's why we want to nip it off at the bud, right? So there's tons of studies out there that complaining is so bad for our environment. It causes that cortisol to be dumped into our system and makes you fat and have a heart attack and stroke. Cortisol is very bad, that stress hormone is. So ultimately, though, the only thing that we can focus on is ourselves, though. And so I want to talk just a little bit about things that you can do to stop complaining, because you're the only one that can really make it better for you. Your control is within yourself. So I've talked about some different tips for other people. The best thing you can do is try to connect your mind and your body. So this came out of Will Bowen's book, A Complaint-Free World. And what I did initially is I'm kind of into like rocks and minerals. And so I had this little piece of selenite and I kept it in my pocket. And every time I complained, I was cognizant of it. I moved it from one pocket to another. So I connected my mind of like, oh my gosh, I'm complaining, to my body. I had to move something. And you want to do that for 21 days. Because if you do something for 21 days, that causes a habit, and then you'll do it more often. So this is just a really kind of an easy way to look at the hierarchy of competence. So in order to live a complaint-free life, which I don't, I'll be completely honest with you, but I live somewhere in the conscious competence stage. So today, most of you probably are at the bottom, right, of this hierarchy. You're unconsciously incompetent. You don't even recognize the fact that you complain or the reasons that you complain. Maybe you just want attention. Maybe you're really bragging about your new car and all the buttons and how you can't use the backup camera, right? So look inside yourself and why you're doing that, complaining. That's going to move you to that conscious incompetence where you're aware of the fact that you complain. And maybe you're going to stop, right? Before you say, oh my God, you see what she's wearing, you're maybe not going to say that out loud, because complaints only happen when it's outside of your body. So you're going to keep that inside, and you're going to do better and better, and you're going to become consciously competent. So unconscious competence in this stage of the hierarchy is that you just don't complain and you don't even think about it, and it's just the way that you are. So I will tell you, in the beginning, when I first started doing this, I was consciously incompetent for a very long time. Every single day, multiple times a day, I'm moving that stone back and forth in my pocket till it annoyed the heck out of me, right? And then I moved it to a bracelet. I've got a John Muir bracelet that I love, and it kind of hurts my wrist. I'm not saying self-deprecation is a bad thing, but I would move that bracelet that was painful from one wrist to another because it was really made me so cognizant of the fact that I need to be conscious of complaining. So that's my advice to you about trying to control your own thoughts, because we don't want another virus around. We want to be an antibody. We want to be a positive person and help people communicate effectively with each other. So great minds discuss ideas, average mind discuss events, and small minds discuss other people. And I love Eleanor Roosevelt, and I think that's a fantastic quote. Hopefully you've gained some bit of knowledge. And this is just one of the things that we can do at North Kansas City Hospital. We don't just only do occupational health and services. We also come and can do wellness, education, and this is just a little tidbit of that. I would be happy to answer any questions that people may have. And thank you so much for your time.
Michelle, thank you so much. We do have a few questions that, oh, I'm sorry, guys. Again, getting used to this virtual world. First question is, what was the book that you referred to when earlier? And that came from Debbie.
So there is a book called A Complaint-Free World that is written by Will Bowen, who is a local motivational speaker here in Kansas City. It's fantastic. It's a quick read, maybe 120 pages. I've read a lot of books about complaining. One of the other books I really like is A Happiness Project. And that's also a Kansas City native. She went to Pembroke Hill, and her name is escaping me, but Happiness Project is the name of the book. Fantastic. Talks a lot about complaining and how stopping complaining can help your happiness.
We have another person that is anonymous question. How do you deal with toxic people that complain? In their eyes, you can never do enough to do it right.
Yeah, so, I think that probably what's going well would be the quickest thing. You can, get those little mantras that just roll off your tongue when people come and they complain to you all the time. You can hear them the first couple times and then you can respond with, hey, yeah, I hear you. And that sounds really rough, but what's going well, right? And you just keep asking that question and eventually you'll win them over, hopefully. Or they'll notice that you're just not going to tolerate all the complaining.
Earlier, you mentioned a company that had a policy about complaining. What is your experience with company morale? What can a company do daily or boots on the ground?
I think it starts with leadership. I really do. I mean, what a great leadership lesson that I learned from this guy at this hospital. It was just really recognizing that somebody has to say it out loud, right? That somebody has to acknowledge the fact that being positive matters and being negative does matter. It creates this sentiment of negative energy. It causes that cortisol. It shrinks your hippocampus, which mimics Alzheimer's. I mean, there are real physiological things that happen in the body when you're around people that complain. And so you need to have the leader step up and say, hey, this isn't how we want to be. We don't want to treat each other this way. And having those conversations, those side conversations of like, hey, no weeds in this garden. Let's go ahead and talk about, positive things. So I think it starts from the top and really works around you and holding each other accountable. So I even find myself, maybe talking to a peer and I start to complain and, I have to catch myself and I say, oh, that was negative, right? And so you have to have your own conscious confidence too and recognize that you're doing it yourself. And I think people, when they see you stop yourself and say out loud, oh, geez, that was negative, that's saying a message to everybody around you of like, I don't want to be that way and I don't want to, be that way around you guys. So I'd say that's my quick, easy lesson.
What age group have you found complains the most in your research?
You know what? It's actually really interesting. So you would think that it would be the elderly because as we get older, we decay or there's more to complain about. It's not. It's actually the working. So ages 50 to about 55, those people kind of ending maybe the 3/4 way through their career, they seem to be the most negative in the research. So kind of interestingly enough.
Again, we have another anonymous, and apology. Again, what is the name of the book? I would love to have our management team read it.
It's A Complaint-Free World.
And then Sorry. You were talking about the hospital having services. What services does the hospital offer?
Oh, like wellness services. So, I mean, situations like this, we could come and do a lunch and learn. We've got all sorts of topics that we cover, whether it's giving feedback that manages the relationship afterwards, or clinical perspectives about women and heart disease or stroke or safety. We do things like this where we do happiness, the science of happiness, or complaining, more of the softer skills. We also can come on site and do wellness coaching. We do biometric screenings. We do any type of events. So we are working with a customer right now where we're coming on site for a weight loss challenge, and it's 8 weeks. And every week we come on site and do education virtually for that group and have a contest for the biggest weight loser. So just whatever your need is, we can do it.
All right, guys. Thank you so much, Michelle. The next person that is on the list is my partner in crime, Charmaine Wood. Many of you know her. She has been in the industry forever, and she is going to take us through the virtual tour. So hold on just 1 second and we will connect.
Hi, thank you so much, Michelle. That was a wonderful presentation. I wanted to take a minute to thank everyone for taking time out of your busy day to join us for our Occupational Health and Employee Wellness Conference. We know that your time is valuable, and hopefully you are enjoying yourself. We are very happy about our clinic renovation and excited to share this virtual tour together. After the tour, I will review the different areas shown in the clinic and answer any questions that you may have. Let's watch the video.
I sincerely apologize. You're going live. Ready? I'm going to stop.
What? They did such a wonderful job with this remodel. The first slide that you're seeing is the lobby check-in area. Our lobby has 2 entrances, one side for work injuries. I hope you all enjoyed the tour. They did such a great job with that remodel. The first slide that we seen was the lobby, the check-in area. The lobby has two entrances. One side is for work injuries and any physician services. The other side is for ancillary services such as drug testing, audios. And as you noticed, the waiting room chairs are socially distanced, 6 foot apart. The next slide was the breath alcohol testing area. The breathalyzer is in a secluded room. The breathalyzer is calibrated daily for accuracy, and the staff is BAT certified. The next area was the drug screen area. The clinic follows all DOT guidelines for testing, lockers for the belongings, bluing in the toilet, no running water, etc. The ceiling is solid, no tiles to hide anything, and the staff are all certified collectors. The next slide, the audiograms. The audio booth is calibrated daily for accuracy, and the staff is KOC certified. The radiology room was next. We do have digital x-ray, and the techs are ARRT credentialed on medical imaging. The next slide was the exam rooms. We have 9 treatment rooms, which we're proud of. Just very basic rooms for follow-up on injuries, physical exams, etc. We have the PT tables so that the physicians can maneuver and be able to give a thorough exam. The procedure trauma room was next, and we do have 2 trauma rooms. They have the gooseneck trauma lights, the trauma chairs for physicians to have easy access to the patient. Everything is at finger's touch. Laceration trays, etc. The next, which is really exciting, is our therapy area. We're proud of our state-of-the-art physical therapy department that specializes in occupational medicine. My favorite is the workplace simulations for post-offer hiring and fit-for-duty exams. The next slide was the nurses station. The nurses station is surrounded by all the treatment rooms. The nurses are able to quickly do their paperwork in order to help with their throughput times. The provider area was next, and we do have board certified occupational medicine physicians that ensure employees' injuries are treated in a cost-effective manner without compromising care. And then we had the checkout. So that was kind of a quick rundown of the clinic renovation. We'd love to give you a tour, an actual tour of it. Of course, with the COVID, things are a little sketchy. I mean, people aren't wanting to get out much, but we would love to give you that tour. And we do thank you again for sharing the virtual tour. We can go now to questions. I would like to mention too, the occupational medicine physicians that we do have on staff, there are 4 physicians, all board certified. We have Dr. Brown, Dr. Hamedi, Dr. Hutchison, and one other doctor. We also have 2 nurse practitioners that are experienced in occupational medicine, which I think really does help as far as controlling costs. They know what they're doing. Any questions?
All right, we've got a question from Lewis. Where is the campus clinic located? Is it on the hospital or in the hospital?
It is on the hospital grounds. It's a freestanding building and very easy to find. It has its own entrance, and it would be as you're coming up the driveway into the hospital. It would be the first left parking lot, and you just walk in those glass doors and you're right there.
All right, the next question that came in, I know you talked about physicians earlier, but how many physicians do you have at each clinic? And then where are each, what days are the doctors there?
We do have 3 doctors at our campus clinic, and one at, well, actually 2.5, I guess, at our campus clinic. The Riverside clinic has 1 doctor, Dr. Brown, who works Monday through Thursday, and then Dr. Hutchison fills in on Fridays. So one main physician at Riverside. We believe in continuity of care. So if you are seen with Dr. Hamedi, that's who we try to schedule your follow-up visits with as well.
Next question that we have, can you explain your emergency room for injuries aftercare for after hours?
Yes. Our emergency room for after hours, of course, is 24/7. Our physicians are trained in occupational medicine, not board certified, but they are trained. So they understand and are very cognizant of what constitutes a recordable, and attempt to treat an injury as a first aid as much as they can possibly do without compromising the care. We also have a nurse case manager that will communicate with you to let you know the treatment that was administered, what if any follow-up is necessary, any prescriptions that may be prescribed to that person, drug screen results. They just, the status reports. They communicate everything with you and keep in touch with you so that you are continuously in the know.
Next question, and this seems to be a popular topic, about COVID. What is the protocol for COVID testing at the clinics?
We have 1 clinic in Riverside that is dedicated to the COVID testing. It is a drive-through, so nobody actually comes into the clinic that is going to be tested for COVID. The drive-through works very smoothly. They have an appointment. They will show up at the clinic at their appointment time. The technician comes out and does the COVID test. They wait 24 to 48 hours, and then they wait 24 to 48 hours, and then the results are in. And if they are positive, we have a nurse case manager that will follow that as well. She will communicate, or he or she will communicate with that patient, answer any questions that they may have during that period of time, give them direction on little treatment plans, and just keep that patient in the know.
You guys have 2 locations. Do they both offer all services?
Our Riverside clinic does not have a physical therapy department. So if part of your post-offer employment plan is to require a skills agility test, for example, they would need to go to the campus clinic for that service. The campus clinic is where we have our physical therapy, our agility testing, job simulation, everything is at that clinic. And then once again, the only clinic that does the COVID testing would be the Riverside Clinic.
A follow-up question to that. Do you guys provide on-site COVID testing?
We do. We do have on-site COVID testing where our nurses will come on site and we can either do the drive-through, we can do inside testing as long as we are in where there's a place where we can socially distance. But we do the on-site, any type of on-site services that you may want. We are able to do, we've been doing a lot of flu vaccines on site, and that's kind of over with, but we will continue to do that if anybody has that need. We can come on site, do your employees direct or flu vaccines, COVID testing.
Thank you so much, Charmaine.
Thank you so much.
We are going to transition and turn it over to our next speaker. Our next speaker comes to us from Marshfield, Missouri, Director Fraker. He is the director of the section for medical marijuana and regulation for the Missouri Department of Health and Senior Services. I'm going to let him do a little introduction and then we will get started on how cannabis affects the businesses and medical marijuana regulation in Missouri.
Okay, thank you very much, Casey. I appreciate being with you today. I wish we were in person. These Zoom meetings are getting old, but we'll do our best. And
Director Fraker?
Yes.
Can you unmute yourself?
Oh, I thought I did. Okay. So, can you hear me now? Okay, we good now? Okay, great. Thank you. Sorry about that. Yes, glad to be here today and be a part of your presentation and try to give a little bit of an update on where we are with medical marijuana in Missouri. I'm Lyndall Fraker. I'm the director of the Department of Health and Senior Services section for medical marijuana here in Missouri. We began this endeavor about 2 years ago, actually on November the 8th of 2018. Amendment 2 passed with an overwhelming majority vote, 66%. And we began our section for medical marijuana just shortly after, about the 1st of January of 19. So coming up on 2 years. Done a lot of work, got a lot of things that's a lot of water under the bridge, so to speak, but we still have a lot of work to do. And there is product available down in Missouri. But we'll go ahead and start the slideshow here if you want to move on to the next slide. Okay. There we go. Okay. Can everybody still hear me? All right, thank you. Okay, Article 14 of the Missouri Constitution that was passed, as I mentioned, on November the 8th of 2018, says that the patients have a right to discuss freely with their physicians the possible benefits of medical marijuana use and to be able to use medical marijuana for the treatment under the supervision of a physician. Now, nothing has changed from the federal illegality of marijuana. It's still federally illegal, but fortunately, the federal government has allowed states to be able to do what the citizens of those respective states have wanted to do in pertaining to medical use of marijuana and recreational in some states. Next slide, please. Our medical marijuana regulatory program is funded by the Veterans Health and Care Fund, which consists of revenues from licensure fees as well as a 4% sales tax on the retail sales of medical marijuana. This fund was set up by Amendment 2, which is now Article 14 of the Constitution, as a new fund that's guarded by the Missouri Treasurer, and it's administered by the Missouri Veterans Commission, which is a gubernatorial appointed commission that's was already in existence here in Missouri. So they're the ones going to be to determine what proceeds after all the bills are paid, where that will go for our Missouri veterans. I might mention that the normal sales tax of, say, in my hometown of, I think it's 8.125%, local, state, and county tax will remain intact. So all that sales tax will be collected on this product at the retail outlets. But then in addition to that, the 4% will be tacked on. So in my hometown, it'd be a 12.125% sales tax on the medical marijuana products. Next, please. So our program is a program that provides safe and secure access to medical marijuana for qualifying Missouri patients through consistent regulation, enforcement, and education. And, you know, the one thing that we've tried to do since the very beginning was be extremely transparent. We wanted to make sure that we went to organizations like all the law enforcement community here in Missouri, Sheriff's Association, the police chiefs, the Narcotics Association, Highway Patrol, and get their buy-in, make sure they knew what we were up to and what we were doing to bring this formerly illegal product into our state. And quite frankly, that has paid off tremendously. All of those organizations have been extremely supportive. They've been our partners in this. We understand that, you know, there's still a lot of anxiety toward having marijuana, part of it legal. And so we've tried to make sure we do what the patients of Missouri and the citizens and the voters ask us to do. And that was a very, very well-regulated, safe program that offered this alternative medicine to patients. But again, keep it out of the hands of those that shouldn't have it. Next slide, please. So far accomplishments that I might mention that we transferred $2,135,000 to the Missouri Veterans Commission back in September. We still have a fund balance of about $14 million. Now that's probably a little more than that right now, but and that, of course, that money again, we pay the bills out of that, and then at the end of the year we have to send a budget request to the legislature to approve how much we want to transfer, even though it's a self-established fund, they still have to approve the transfer. And we'll be doing that with the new budget year coming up. We'll have that amount for the next transfer. It took us about 21 months to open the first dispensaries in Missouri. And to compare that to other states, you can see where we would rank. We would rank about 5th. I think Nevada took 20 months, Illinois 22, Arizona 25, Ohio 26, Arkansas. So about 23 months after the passage of November the 6th to the first sales in October, put us right in there. The national average of 29 months for implementation is that's the average. And then of course, we were only 5 states. There were only 4 states faster than us, I guess. Next, please. We met all the constitutional deadlines for program implementation, making available, accepting, and processing applications. We completed our first program year on December the 6th of 2018, or sorry, on December the 5th of 2019. That was the first full year. And we sent an annual report to the governor, which is mandated in the Constitution. We also accepted and processed over 2,270 facility applications for licensure, and we thought we would have about 1,000 maybe. And it was very, very overwhelming, the amount of business applications that we accepted. And then we are over 60,000 patients. We're getting close to 70 now, actually, about 67,000 patients right now that we've approved since June the 28th of 2019. So in a little bit less than a year and a half, that's how many patients we have. This last line is not necessarily our goal, but what the industry told us and what other states told us is that we would have somewhere between 2 to 3% of our state population that would become patients, which Missouri has about 6.1 million patients. So that would be somewhere between 120 and 180,000 patients after the third year. And again, we're already at getting close to 70,000 patients after a year and a half. So we believe we're well on track for that. Next, please. So during COVID, certainly issued some challenges. We continued our implementation process. We continued completing all of our minimum standard verifications, our commencement inspections. Back on March 26th, we added a digital barcode to the back of patient and caregiver cards for an added layer of security. And actually, you know, we being the only department that has authority to issue patient and caregiver cards, just had a lot of challenges and a lot of work to do, but really didn't miss too many days with COVID in our department. Once we got some of our offsite IT systems figured out where we could do some of our folks could do a lot of their work offsite, it went really very well for us. Now, there's certainly several facilities out there working on getting their business licenses that were delayed because of maybe subcontractors that couldn't do what they needed to do for a while and things like that. Local city building codes, things of that nature where they were delayed. But as far as our part, we were able to continue to operate. On July the 1st, we had a little fee increase. That was per the Constitution, like a cost of living increase for fees for patient cards and what have you. I think it amounted to 58 cents or something like that. $25.58 now to get a card. So some other accomplishments. We have 52 positions in our section, and we have them all staffed right now. We have a very robust website. As a matter of fact, anything you want to know about our program is on our website, and medicalmarijuana.mo.gov. And I would suggest that you do a little bit of snooping around there. You can find anything you want to know about what we're doing, and we have a really good team that works on that and updates it daily, actually. We have educational materials and video tutorials available on that website. And the other thing that we've done, over 112 public presentations in that first year. Now, that's certainly slowed down since COVID. I did some in January and February this year, but then we kind of shut that down for a while. I'm kind of back doing some now a little bit, traveled the last couple of weeks. But again, part of our transparency, part of making sure the public we took feedback as we were developing the rules, was a very important part of our program, and those public presentations really help us to build those partnerships. Next, please. Regulation changes. The department's always cognizant of the fact that we have real changes and the impact that they're going to have on the licensees. So we try to seek input from the licensees regarding real changes, post any real change to our website, and communicate directly with the licensees regarding any real change. And this is an example of what you'll see in our website for the draft rules. And again, that as we were building the rules, which we started in January of 19, completed them by May of 19, it was very important to get these draft rules out there on our website, seek input, and people were very good to help us as we were building those rules. Next, please. These are just some examples of some recent rule changes that we went through and kind of how we do it. One involved physicians, dispensary facilities. Again, all of those amendments can be reviewed at our health.mo.gov safety medical we're on the draft rule address there. Next, please. We also have the legislature when they're in session. That there was a couple of things that they wanted to have done this past session, and so on July 13th, the governor signed HB 1896 into law, and we will be promulgating the rules regarding the pre-approval of THC-infused edibles and packaging. I think it was Senator Onder sponsored the bill, and just some things to do. We didn't disagree at all to help maybe identify the difference in THC-infused edibles and candy, so to speak. So those were some good things that they came up with to help us with our packaging and what have you. Next, please. Now, our patient services team, we haven't talked much about them, but we've got about 10 associates plus our director, Erica Ziegler, and her assistant that works in this area. This team is responsible. They're really the front line of our program. They're answering all the phone calls, email inquiries, processing all the patient and caregiver application. Again, we've had over 67,000 approved. They use their expertise to assist the applicants through the process to create a streamlined patient-centric customer experience for the qualified medical marijuana patients throughout the state. This is our toll-free number over here on the right, and again, our address and all of our email information there. But these folks it's amazing how much work they have to do. Every Monday morning they came in and there's another, few thousand of applications out there maybe to process, or a few hundred at least. And we have to have these per the rules completed within 30 days processed, and we're tracking about 2 weeks. That'll get a little bit better as they catch up. And again, we're going through a period right now where everybody's renewing their card from last year. Plus, now that the dispensaries are coming online, we're getting a lot of new patients, so they're pretty heavily inundated right now. And just our hats are always off to these folks because it never lets up. Always lots of processing to do and calls to answer. Next slide, please. We have a subscriber list and a patient services newsletter that's available out there, and this is again on our website. You certainly can sign up for that if you're interested in updates from our program, and we encourage that. Next, please. Now, these are just some patient numbers as of November the 16th, which is a couple weeks old now, but we've received over 87,000 applications for either a patient license or a caregiver license or a home cultivator license. We had approved 66,000 at that time, caregivers 2,103, and then some denials. Of course, denials could be because they have something in their background, a felony offense or something that's, some felonies can be approved, but if it's a criminal offense or something like that. Next, please. We have video tutorials available, again, on our website, some very good tools here that can be utilized by the patients. And those are available if you'd like to go in and have more questions they can help you with. Next, please. This is just kind of a timeline of our licensing and compliance piece. So as I mentioned to you, we had over 2,200 businesses apply for licenses. Now, the Constitution said that we would have a minimum of 348 licenses, and that would be 60 cultivation, 86 manufacturing, 192 dispensaries. The dispensaries have to be distributed within each congressional district, 24 facilities in 8 congressional districts to spread them out around the state for the retail outlets. But that was what the minimums were. We made the decision early on, Dr. Williams, myself, all of our team, that we would stick with the minimums initially in order to get the program up and going, because 60 cultivation facilities was still going to be more cultivation facilities than any other state for medical marijuana states except for Oklahoma. So we knew that that number of facilities would produce enough medical marijuana. Actually, based on what the Constitution said each patient could have, it would actually produce enough for 300,000 patients, which we felt like could do us for 5 years. If we would have issued licenses for everyone that applied for one, if they qualified, but I mean, there were 578 cultivation facilities that applied for a license, and if if we would have issued one for every one of those facilities, it would have produced over 8 million pounds of marijuana per year, which would be enough per the Constitution based on how much they can have for over 3 million Missourians, which would be half the state's population. And some of you may have heard, we took a lot of grief back in the spring why we didn't issue a license to everybody that applied. Well, that's the reason, because we knew that surplus would do nothing but supply the black market and young people and people that shouldn't have it. So we stuck with those minimums. We can always issue more licenses if the need, if the need comes up, and we will. But we're very proud of keeping this program very tight and well regulated. This is a timeline again of when we had to have the licenses back and issued, and then when they had to have them completed, all the facilities. And we're coming up on that year now on all of our facilities, and that's why we're just really busy right now. So we had 15 approved to operate at this time. When we did this 2 weeks ago, we're now at 30, and we have about 35 more that are requesting their commencement inspection. So coming on pretty fast right now. Next slide, please. We also have a minimum standards review. We've actually completed all of those now. I think when this slide was done, had a few left, but basically a facility will be granted the final approval to operate upon passing a commencement inspection, which has to be done within a year. And then also we have to make sure all those minimum standards are met prior to that. Next, please. The commencement inspection as of October 23rd, the total number of licensed certified facilities requiring commencement inspection is 371, and that is subject to change. And as I said, we have 30 that are approved right now, so we still have a lot of work to do. Next, please. And then we'll have to complete all those minimum standard reviews before we will issue a change request. We've had well over 100 change requests already that have been asked for, and we've approved many of those, but there'll be some more, I'm sure. Things like changing locations because they lost a lease on a building, or all kinds of reasons. But we're at that point in the program right now, getting all those requests approved or denied, one of the two. Next, please. Okay, another piece that we have to do is we have to actually approve and certify every employee that works in the industry. And as of November the 16th, we had received 785 applications. These are called facility agents, 785 agents, and we'd approved 724 and we denied 41. And again, they have to meet background checks and a history of their criminal history and that type of thing. So another piece in the puzzle that we have to do. We expect to have somewhere between 9,000 and 18,000 facility agents within the first 3 years. Next, please. And this is just a little more information about the agent ID cards. They are transferable. They're good for 3 years. Like all employees, from the janitor to the owner, have to have this approval. And then there's some special things we can do for contractors that are in the building, temporary, that kind of thing. But next, please. We also have to issue certifications for anyone that's going to transport products. So along with those 371 facilities, then transportation facilities are on top of that, and there was no limit on those. So if you apply to become a transporter, we'll have to approve you, but there won't be limits there. And then seed to sale is another piece that we have to approve, and this is the you might say the IT POS point of sale companies that each facility has to employ in order to be able to do their IT work for the seed to sale tracking, which is where we track all the product, and that's always available to us here at the home office of where marijuana starts and where it ends in the patient's home. And we have to certify those companies that are going to be doing that for these facilities. Next, please. This is just another interesting piece here. I mentioned a little bit of it a minute ago, but 348 facilities, which 60 of those would be cultivation facilities, and then the rest are manufacturing dispensaries. They could annually supply 900,000 pounds of marijuana to serve the 300,000 patients. And again, if we would have done all of the facilities, it would have been enough to serve almost half of the Missourians. Next, please. 60 cultivation facilities in the state. Now, when we issued these facilities, what we did was we used a third party. We blinded the applications, so they didn't know who the people were. And then all the criteria, there was probably, I can't remember exactly, but 170 some, well, there was over 100 pages of criteria per application that had to be reviewed. And as it turned out, quite frankly, the facilities are distributed around the state fairly well. Certainly they're clustered in Kansas City and St. Louis here on the cultivation side, and you're pretty sparse in the north and down in the south central part of the state, but all in all, fairly evenly distributed to be able to get the cultivation products to the facilities, you know, as quick as possible. Next slide. And this is the dispensaries. These are the retail outlets. So these are the ones that really are important for the consumers, the patients, and they're distributed around the state fairly well. And again, there has to be 24 per congressional district. There's 8 congressional districts, and that was per the Constitution. That was all factored into the scoring process and what have you. And then next slide, please. Manufacturing facilities. These are the facilities that the cultivators sell the product to, and then the manufacturers process the product into edibles and oils and all the other kinds of products, the non-flowering, the non-smoking products, you might say. The cultivation facilities can sell the flower product, the raw product, directly to the dispensaries that would be used to, you know, to smoke. But if it's going to be processed in any other form, it has to go through a manufacturing facilities. So there's 86 of those, and they're distributed around the state. Next, please. There's 11 testing facilities. This was very important, and I'll tell you, the Constitution actually only had 2 testing facilities that were required, and we made that decision early on to go ahead and issue, after talking to various industry leaders and what have you, to issue licenses for up to 10. As it turned out, we actually did 11, technicality, but this is a very important part of our piece here in Missouri. In some states, like Oklahoma that I mentioned, they don't even require testing. Now, I understand they're modifying some of their rules, and now they are requiring some testing because they found out what kind of a disaster it was to not do that. But testing is very, very important, and we've already, in our short time with facilities open, had 1 mold and mildew issue that fortunately turned out to be okay, but this is just an important part of our Missouri program, and we're proud that that piece is in there and was put in there by the voters. Next, please. We also have, right now, we have some transportation. This is on the left side of the slide. That's wrong. That was the testing number there. But we have some transportation facilities that are already approved. And again, they have to be independent from, they don't have to be independent, but they have to have their own license to transport. So a cultivator or a dispensary can transport if they apply for a separate transportation license, or it can be a freestanding transportation company similar to an armored car service or something like that. But security is the key on this. And as you can imagine, just transporting hundreds of thousands of dollars of product at one time in a vehicle out there on the road and getting into a routine, you know, it could be staked out and could become a real issue. So there's a lot of qualified security transportation companies that'll be transporting this product. Next, please. Again, these are just some tools that are available on our website. This conversion chart's a little card we came up with that can be carried in the purse or the wallet. And so if a patient goes into facility, it can tell you what the conversion ratio would be from going from grams to milligrams or ounces to grams, that kind of thing. And then we also have this patient information booklet that we put together that's really good tool that is out there and available for patients. And then there's a physician brochure on the right that we put together to help physicians. The one thing about Missouri's program, many states require physicians that are going to certify patients to be certified. In other words, if you want to be a medical marijuana physician, then the state will have to give you a special license for that. Missouri's not that way. Our program was set up with a patient-doctor relationship. So if you're a doctor that's licensed in good standing and you're a medical doctor, an MD or a DO in Missouri, then you can certify patients, so you choose. And so that's another good thing about Missouri's program is we're not to stand in the way of that relationship between the doctor and the patient. Next, please. And again, we have to send an annual report to the governor. We also have monthly reports, and we post these on our website. Right now, you can see these charts that are issued here or posted here. They're on our website showing the progress of our facilities and different information there. You can see at the bottom, qualified patients by age, qualified patients by condition, all that. So, and it might surprise you if you're a numbers person, you want to get in and do some digging around. Some of these charts are pretty interesting. It might surprise you the age groups of some of the patients, and some of that information is kind of eye-opening, actually. Next, please. There's also, this is kind of a history that's in our website. You can kind of read all about where we came and where we're heading, and just a kind of a line-by-line history of our program. We actually have 3 sections within our department. We have the compliance and licensing section, our director, Andrea Balkenbush, and then we have the patient specialist team that I mentioned to you earlier, Erica Ziegler, and then we have a third piece, and that's our kind of our operations department, and that's led by Charlotte Kroll. And Charlotte and her team are the ones that gather all this information, put together all the PowerPoints, that do all the patient booklets, all that kind of stuff. She also is in charge of our budgeting process, working with the Veterans Commission and the legislature budgeting process and all that. So all 3 sections are very, very busy all the time, and they do a great job. Just very fortunate to have a wonderful team. And then my assistant, or our deputy director, Amy Moore, who's also legal counsel. She's phenomenal, and kind of the brains of the whole organization, quite frankly. Next slide, please. These are just some little slides that they put in there showing, we've had a lot of media coverage. Seems like lately it's been a little bit lighter since the election, but just really had a lot of things out there that people kind of took some shots at us. They thought we ought to do this or do that, but we've stayed true. We've stayed to our original plan, and we're very proud of that. Put together a program that's, I think Missourians will be proud of in the long run, and we stand by that. But these are just some information that's out there that you can research, Google, whatever, and you'll find all kinds of stuff. But all in all, our program compared to other states has been at the very top, quite frankly. Next slide, please. Next slide, please. We have a feedback page on our website, and we welcome that. Anything you'd like to share with us, we certainly listen. As I mentioned, I've done 112 presentations. I've never turned down a meeting with anyone. If someone calls and says, "Hey, let's have a meeting," or "We want to talk to you," we've always tried to accommodate and made sure of that as we go along. Listen to you. So send me an email if you have anything you want to talk about. Next. And I think that's pretty well it. Again, medicalmarijuana.mo.gov. There's our 800 number. And appreciate y'all giving me time today to give you an update, and I'll be glad to answer any questions if I can.
Thank you so much, Director Fraker. We appreciate all the information. I do have a few questions here.
Okay.
How will medical marijuana affect the workplace as far as drug testing and the levels that should be tested?
Very good question. And I will tell you that the amendment, which became Article 14 of the Constitution, did not give us the authority to give specific direction to employers on how to handle that. So what we've told people all along is that get with your HR departments, your legal teams within your companies, and make sure that whatever policy changes you're going to make, get them done up front. We're already into the program now, but drug testing can still be done. if some employers want to not allow people to obviously be on the clock with marijuana in their body, they probably will get challenged. Now, they can't be under the influence. The Constitution still specifically says that an employee cannot be under the influence. And so I know sometimes that gets a little bit hard to tell, I guess, whether they are or not. But all I can do there is suggest that you get with the attorneys for your companies, and most of them have been looking at these issues. So far, there's not really a good, you might say, roadside sobriety test for even law enforcement to do for marijuana patients. There are some out there, but the equipment's not readily available yet. But I think it's coming, and that's going to help once they get that in place. But right now, they're relying on the old-fashioned roadside sobriety testing, and they all have ways of doing that. But our department does not give direction on that. It has to be done by your HR and your legal teams.
This question comes via anonymous. When do you think recreation marijuana will be legalized in the state of Missouri?
Well, my anonymous answer would be, I believe you're going to see it on the ballot in November of 2022. And the only reason I know that is because there was a group, and many of them were the same people that put this one on the ballot back in 2018. There was a group that was working on an amendment, and matter of fact, they were well along when COVID hit. And so that stopped them from getting the signatures out there in time to get it on the ballot for November of 20. And they've told us that particular attempt will be out there again in November of 2022. And I can tell you the one draft that was out there then, and I'm assuming that the one that they're going to be working on will be similar to that. I can't tell you for sure, but the one that was out there then was kind of a Section 2 of Amendment 14, or of Article 14, which this is Section 1, our program, and it would put it under the Department of Health. I mean, it would be another part for us to have to oversee. So I'm not advocating for that, but I'm just telling you that's what they've told us, and that's what to expect.
This question comes in from Michelle. Where is the most populated area that you received applications?
I don't have that information at my fingertips, but I can tell you it would have been the St. Louis area. I couldn't give you specifics there, but the majority of our applications are certainly from the Kansas City and the St. Louis areas.
This next question, do you have any references or sources that you can send to us where they can start creating those policies?
Start creating which policies now? On the employment stuff or what?
Yes, the employment.
Okay. I think our Department of Labor probably would be the place to go for that, because they've been working with employers and they've had communications with employers on how to do some of that. I also think there are some labor attorneys out there, employment law folks that are experts in this, and I've attended some conferences where some of those have presented. Groups like the Association of Industries of Missouri, AIM. I don't know if you're familiar with the AIM Association, but they would be a great resource if you reached out to them and asked them for information on that. And I'm sure they could refer you to some employment law attorneys that have been studying and doing this since its inception. But we don't have anything specifically within the Department of Health on that.
Referring to your charts, you said that there was a particular age group that we would be surprised by. Can you elaborate?
Yeah, you can click on there and see, but it would surprise you the amount of senior citizens, I think, that are finding that medical marijuana is an alternative medicine for them, whether that be a Vietnam veteran that's, a PTSD patient, or they're just reaching that point of life that they don't want to just load themselves up with a bunch of opioids for whatever ailment they have. And I think it was kind of eye-opening to see that that population, even though they grew up through the stigma of marijuana being illegal, I think, especially the 60s and the 70s and the drug, say no to drugs and all of that. But I think you'll find that those folks are now seeing that that it is an alternate out there for them, alternate medication.
Well, that is the end of our questions. Director Fraker, I thank you so much for joining us today. Very
Absolutely.
interesting, I
Anytime.
must say.
Anytime.
And have a great day.
Thank you, and I'll be glad to come back anytime.
I'm going to close this out, guys. Thank you so much for joining North Kansas City Hospital Meritas Health team today. We got to hear from 3 extraordinary speakers, ranging all the way from OSHA regulations, reports, special circumstances, with Sharon Mount, the science behind what happens to your brain when we complain, which I'm going to put that in my tool belt to not complain. We'll see how well that works with Michelle Lane. And then Director Fraker speaking to us about the Missouri regulations regarding cannabis and businesses. I hope you enjoyed the virtual tour. The tour that you saw today was at the campus location. If you are wanting to see the renovations in person, please reach out to Charmaine Wood or myself. Erin O'Neill, the practice administrator, did an amazing job when she designed the renovations, and they are very impressive in person. If you have any questions about our service lines, whether it is employer wellness services and doing an on-site biometric screening with nurse counseling follow-up session, whether it is COVID testing on-site, drive-through at our local clinic, if you would like to add services to your protocol via the clinic, give Charmaine Wood or I a call. In your packet on the agenda page on that back side, you will see our information and our contact information. So please reach out to us. We are here to help you. And then in closing, there will be a follow-up survey. It is 2 questions. We want to know what you guys want to see next. And then if we could find out what you're currently using, we would love to hear from you. So please, please fill out that survey. Again, thank you so much for joining us today, and have a great rest of your Tuesday. Bye, guys.